So this is you'll never quite find a panel with all these different type of experts here. It's quite a hodgepodge of different things, but as you know from this weekend now, they all relate in some way. And we have to figure out how they connect. That's always the difficult part, but there's just a couple things I want to go over before we then open it up. Sleep has been commented on a lot, for all these different sessions, and tomorrow we're going to focus on sleep. There's a sleep expert coming that I work very closely with for Chiari patients and concussion patients because of the parallels. We've talked about some of these, and I think that'll be kind of fun for you to hear kind of how they think about sleep, what analytics they use, what you could do on your own without having to see someone like that, and then more sophisticated things they're doing. Doug Siddell will be here, who's an ENT physician that deals with a lot of the obstructive sleep issues, which can really haunt some of these kids with Chiari. Central apnea we've talked about, but the obstructive apnea is also can be very difficult. He'll touch on that, as well as hypnosis. We'll finally hear Dr. Lazarus talk about that tomorrow. On the East Coast, when I was at Duke for a while, the carbon monoxide, the lead, particularly in these old homes, were a problem. And I had a couple Chiari patients that had so many different symptoms and were found to have, one was carbon monoxide actually, and one was lead. And it's something we have to think about, but I don't know if you can comment, is there anything in the history that would make you, go down that path? Because that's a pretty big path to prove, right? I found it a difficult thing to do all the testing. But is there anything you'd recommend in the history that you might think about that? Or in other words, more symptoms in the house or anything like that?
Yeah.
If you can just use the mic.
Sure, right. Well, there was one patient who said that when her sister came back from college and they were staying in the same room, that her sister started to get headaches and hadn't had headaches before and went back to college and didn't have headaches again. So that did make me think about environmental factors. Yeah.
Yes, is there a question about that? Okay, well, we'll get to it. One sec. The other, I just want to get these off my chest, then we'll be done. The other is the occipital nerve. So Chiari surgeries, if we go out a little bit too lateral or we do cautery over there, we can catch that nerve, and that's a very real issue in post-decompression, that occipital neuralgia. Also a shunt kid, that path of that shunt is going right next to that nerve. So when we're injecting that nerve, we're a little bit tense because the shunt's right there. Dr. Gliano and I had a patient recently, we're both there, we're watching that shunt, and it's safe. You could still obliterate, and now they do freezing and different other ways that are more non-invasive, meaning without requiring needles maybe. So that's something that's definitely worth thinking about in terms of these trigger point.
Or acupuncture.
Or acupuncture. Mm-hmm. You want to comment on acupuncture?
Well, I am not the one doing it like Dr. Galliano, but she often will do, so Dr. Galliano will actually work on acupressure and acupuncture first around the occipital nerve before actually doing the injection, the occipital nerve injection to help desensitize it, and that often is more successful for children.
And one more thing is, it came up yesterday, there was a question about Chiari, and if someone's pregnant, do they have to have a C-section? And I just wanted to have Dr. Kua, the expert, talk about that. We were chatting about this earlier. Sort of what's known about that, or what should the OB physician know?
Well, what we went through in my talk was that a lot depends on the individual circumstances for the woman. If someone has not had prior surgery and they have a very impacted brainstem and possibly an active syrinx or a significant syrinx, then that might together indicate a C-section might be appropriate right from the get-go. But if someone has had decompressive surgery, they have an open cisterna magna, they don't have a syrinx, which is generally the case in most Chiari patients, they have all the options they would otherwise have for labor and delivery.
Yeah.
I don't know, does anybody have any specific question about that? Because it's a misconception that everybody with a Chiari needs a C-section for delivery. It's not.
And just in terms of Nancy, I don't know if you can comment also about EDS in terms of the other Stanford. We've had this issue where the genetics won't see many of these patients anymore. And it's become a problem because we just want to make that diagnosis. And we've talked about the age issue. Tarike talked about that, being young, and can you really, go through these criteria versus some of the genes are still unknown. They may come back and say, okay, you don't have it, but could you still have some other variant? Is it even worth genetics getting involved? Or what's, do you think, the role? Do you encourage that in your team?
I do think, and I said this during my lecture, that I do think that a geneticist is necessary, especially if they show signs of the VEDS, the vascular form, because that needs to be managed on a whole different level. The difference between classic and hypermobility comes with post-surgical complications with wound healing and things like that, which I think are necessary to know about. The hypermobility type doesn't have the genetic marker, and so what they've been doing, from my understanding of a lot of genetic evaluations, is if they don't have the symptoms of classic and they don't have the symptoms of vascular, they don't even want to see them. They just say, okay, you have hypermobility. And at the conference, they were even suggesting that therapists even have the ability to evaluate, because we are trained in goniometry, and that's what we do, is measure and look at the body and the movement and things like that. And so they're trying to broaden that. I know the primary care doctor I have gives them that diagnosis, just puts that code on there, because he can't get them in anywhere. When you have to wait for a year for a diagnosis, it's not helpful. So.
Great. Okay, let's open it up. I got all that off my chest. I feel better. Yes.
I just have a question about Chiari headaches for really the neurologists, I guess. It was interesting yesterday when they presented the results, or the tentative results from the study that Dr. Iskander and Dr. George are doing through ASAP, and they said 35% of the kids had frontal headaches. And I think some doctors disregard that as a Chiari headache, and I was just wondering your opinions on it.
So I think whenever I encounter refractory headaches, I'm thinking back, what am I missing? What am I missing? Even with a frontal headache, I will do a brain MRI if things aren't working, right? And if I see a Chiari, I will pretty much send them to Dr. Grant and work on it together. So to me, it's not an exact fit that it has to be a posterior headache.
I think there's two things to remember in Chiari in children. One is that children, usually infants under 2 or 3 years of age, oftentimes don't present with headache at all. They present with gastrointestinal problems and are frequently undiagnosed. They have nausea, vomiting. They're treated for reflux. They're treated for with Nissen plication, sometimes surgical treatments for reflux and vomiting before the Chiari is discovered. As far as the slightly older children, I think one thing that is a little bit mystifying is when you talk to kids that may have been symptomatic from relatively early, because, the progression of Chiari is really almost an adult progression. So if you talk to somebody who's 35 and who's not had a headache, and then they begin to be symptomatic, they know what a headache is, and they know what headache isn't. But generally, teenagers and younger children, you can talk to them. I've talked to them for a half an hour, and they don't understand what a headache is. They've always had a headache. They've always not felt right. They've always had something in their head that wasn't right. And it takes me back to we had a 10-year-old boy who had a Chiari. He was a little bit overweight, kind of a couch potato type kid, and didn't really interact with any kids on the ward, he had surgery, and a day or two after he had the surgery, he was playing in the children's and the day center there. And here is a kid with railroad tracks all the way down the back of his head. And he said, "How are you feeling today?" He says, "My headache's gone." And, this is an impressive observation because that kid didn't complain of headache before he had the surgery. And surgery can give you a pretty bad headache, and this kid was really functioning a lot better. So a lot of times they just will be not right and they don't know what a headache is. So it's important to kind of get an idea about that. Younger kids, you have to look for headache kind of behaviors. Sometimes they'll bang their head against the wall. They'll massage their head. They'll hang their head. They'll just like what you might think you might do for a headache, they might do, So we've also had kids that will do peculiar behaviors. Sometimes they will shake their heads almost to uncork their posterior thigh. It's the only thing I can assume they're doing. Other children will lay upside down with their feet over the back of a divan and hang their head backwards over watching TV upside down. Now, why in the world they do that? Adults wouldn't do that because they're too self-conscious, but children will do whatever, makes them feel better. So there must be some benefit to some of that, So those are just some, observations from seeing a lot of these cases.
And from the physical therapist standpoint, posture, a lot of the children are chronically ill and they're on their little machines and they're sitting there like this, and I have an awful lot of patients that if you just correct their posture, their suboccipitals get very tight in that position. They get spasmed. You feel their suboccipital muscles. They have the frontal headaches. They have the posterior headaches. And not necessarily from a Chiari standpoint, but there's not a reason why they shouldn't have that as well, that you address their posture and you get them in a more upright position and their headaches go away. And I would say 90% of my headache patients go away with postural correction. Just getting off that, if you look at kids, they're down here like this all day long, so.
Yeah, that's a very important point, I think, among many others that you made. I always give some of the patients my little laptop computer talk because laptop computers are the worst thing for most of these patients for a number of reasons. One, they have small screens, they're very high resolution. Generally, they're used at a table, so your shoulders are up, and they have a platform, so your hands have to be slightly forward to be on the keyboard. It's the worst position for your shoulders. Usually you don't have elbow rests and the hands are forward. So it puts a lot of strain on the trap muscles. And then, of course, what do you do in that circumstance? You roll your head down and you look in because the computer screen is really too low. So most desktop workstations are set up with about a 15-degree down look. So a laptop is much lower, so there's this tendency to tilt forward and hyperextend the neck. And that aggravates all the cervical flow. I mentioned before about this Alexander. We have Alexander techniques have been around for a long time. They started off in Europe with people that were performance. So they don't come from a physical therapy standpoint. They come from a trainer background. And that's not a criticism or an advertisement, but they go through, they just watch posture basically and keep people tipped up on what to do. They have about 1,600 hours of training, and they're a little more prominent on the East Coast and in Europe still, but I've had a lot of success with people, spending a few times with a therapist just to get the idea about what they're doing wrong and how to recognize it when they do it, in terms of how they balance, how they sit, and how they go to standing and stuff like that.
I mean, my algorithm is, if there's occipital headaches, I'm a lot more in tune with the Chiari that, they're so much more likely to get better from that. But frontal headaches, we have to be careful, but about half of those kids will get better with the decompression, but what about the other half? So I think it is important to have neurologists see them and other specialists before we would do something, because it's not a slam dunk. We just don't want to have to operate if we could have, had something, other intervention for them. But you have to definitely keep in mind that Chiari can cause frontal headache, no question about that, and that they can get better. The other issue with frontal headache, or particularly the headaches behind the eye, we think about this whole pseudotumor issue, which can be an problem after decompression as well. So it's something to think about. Always do an eye exam. I do before surgery for decompression because I want to see how their eyes look. There's an autism study. The Columbia group has looked at this whole behavioral issue. Chiari surgery does not cure autism. That was out there in the media, as well as chronic fatigue syndrome at one point. But some of these autistic kids, this is the extreme, can really be derailed, over time. And they can't express themselves. They can't say they have a headache. They have some pressure, which is manifested in some behavior, which is not that different from some other kids, right, who are difficult to express how they feel, especially at a young age. And I've operated on some of those kids, and I've gotten back to where they were before. So it is very real. And the kids that have this problem with the nonverbal communication, they're very tricky because they won't just tell you, I have a headache. They sometimes take their hand, though, and they do hold their head back here. Or some kids hold their head up front, so you can pick that up, but otherwise it's tricky. Yes?
I had a comment. Dr. Fraser Henderson, I think, was funded a little bit by another organization to look at the autism issue. And I'm not sure whether there's really a genetic association with because autism has probably got genetic bases, whether there's a genetic relationship or not. I don't think we're even close to that. But a lot of kids nowadays are misdiagnosed because they're kind of withdrawn. They tend to be sometimes irritable because they don't feel well and they have headache. They tend to lash out, and kids bother them, and they'll stab them with a pencil, they'll push them over. They'll get somewhat violent, and teachers don't, as overrun as teachers are, they can't tolerate that kind of behavior. So we get in a position where we're trying to advocate for kids in the school system because the school system sort of say, let's get them out of school because they don't belong here. They don't fit in, and it's a little bit of a problem. You'd think the school systems would be better in this regard, but they produce a lot of problems and they don't understand. But a lot of that again gets better sometimes with the surgery when the surgery is important. I tend to like aphorisms, and I just want to make a couple of points. One is, you can always have Chiari surgery. You can't unhave it, as some of the some speakers said. You cannot unhave that surgery, and we don't advocate for prophylactic surgery. I've had a few people come in and say, gee whiz, I'm getting married next year. I'm going on a fancy honeymoon. I don't want to have this. I think I'd like to just get fixed before I go down the aisle. And that's not an appropriate. Response. We generally use this Karnofsky scale to see what extent people have significant disability. There are a lot of simple things that can alleviate the problems with Chiari, and unless someone's significantly disabled, surgery is not a good option. We're continuing to learn a lot about Chiari, and the surgery in many more places is much better than it was 5 years ago and 10 years ago. 5 years from now, it may be much better. So you can always wait. We don't see any negative to not having immediate surgery if you're not symptomatic enough to really make that as a choice. So that's my non-surgical opinion about it.
No, it's a very good point. This was the extreme when I was in the Air Force several years ago when a pilot, I was telling this to the kids upstairs, they hate getting MRIs because it shows stuff. And they had a radiculopathy of this pilot down his arm and got an MRI. It showed an extremely tight Chiari with tonsillar descent down about 30 millimeters. And the question was, the Department of Defense asked me, well, can he eject out of an aircraft, F-16, safely? Well, I wouldn't think that would be a good idea, but I think they're more concerned about the plane, than the pilot. So there's a lot of unknowns here, but we do not want to do a decompression on him just for prophylactic use so he could fly an F-16. I mean, that's not the goal here. These are big surgeries. They have risks and they have long-term associated problems that we like to avoid if they're asymptomatic. So we can't be in that business of decompressing, prophylactically. That's a very important point. So, is there another comment? Not about that. Oh, different comment? You don't talk about F-16s. Yeah. But sports is another issue. I have a lot of kids who are adolescents, and they want to know if they can go back and play football. And we didn't get into that whole issue here at this conference, but if you want to, I'm happy to address that individually. It's a very sticky topic. Whether you can play with a syrinx, whether you can play with a Chiari that has not been decompressed, whether you can play after decompression with a little syrinx left. These are a lot of controversial topics in our neurosurgery world. So I'll stop, sorry. Jeff.
That's great stuff. Someone asked before about how young a patient you can treat with biofeedback. I use hypnosis, and I have my talk tomorrow My youngest patient with migraine headaches was a 5-year-old boy who was losing 1 to 2 days a week per life, and after one visit, he was fine. I think, and that's another thing, I mean, we're all focused on the medical stuff here, and tomorrow I'm going to talk about more of the behavioral things. And I think one of the things that we lose track of, you need 2 main things for this to work. You need positive expectations and motivation. And there's something called outcome resistance and process resistance. Outcome resistance means I don't want to change. Now, I'm not accusing anyone in this audience or anyone in this audience's child to not want to change. And when someone has headaches, it's a very complicated thing. And I loved your talk, and there was one slide why treatment doesn't work, and there were not enough medication, whatever, not the right dosage, et cetera. And then there was one small line, psychosocial factors. And when I see kids, that's the biggest line, the psychosocial factors. And I'm going to go through in 3 minutes what usually takes a much longer time to give you an idea. And I learned this from David Burns, who is internationally known in the field of cognitive behavioral therapy, but just to give you a different perspective on this. And I'm not going to talk about this in my lecture tomorrow. So someone comes to me, and the person has headaches. So, gee, if I had Harry Potter's magic wand and I could perform the miracle cure today, what's the cure? Oh, the headaches will be gone. Great. And again, I'm not speaking to the Chiari business right now. I'm just talking about headaches in general. So, and if there were a magic button on my desk, you could press the button and the headaches go away, would you press the button? Well, who's going to say no to that? Great. Well, it turns out I can teach you to control those headaches. On the other hand, I'm a little hesitant to. I'm reluctant to, because I can think of reasons why you might not want to press that button. And then people look at me like you're looking at me like I'm from Mars or something. And so let's make a list of reasons not to press the button. I get extra attention. I get extra sympathy. I don't have to go to school. I get out of certain chores. It protects me. If I have a headache, I don't have to go to school. I don't have to take the test, and then I won't do poorly on the test. And you come up with a list like that. I know I'm going quickly on this today. So gee, John, gee, Jane, given all those good reasons, why would you want to get rid of those headaches? And so that speaks to what's called outcome resistance. And these are all unconscious reasons. People don't stay up at night thinking, oh, I know, I'm going to keep the headache so I can, get out of school tomorrow. This is all unconscious. I get to play video games. And then the child says, well, yeah, I want to go to school. I want to be with my friends. I want to play my sports. Which side weighs more? Is it the side to keep the headaches or the side not to keep the headaches? And then let's say a kid wants to get rid of the headaches. Then there's called process resistance, the process that they have to go through to do this, whether it's cognitive behavioral therapy or hypnosis or whatever it is, the homework that's involved. Oh, you mean I have to do homework? You mean 15 minutes of homework a day? No, I'm too busy doing my video games. So the psychosocial factor, as David Burns says, the agenda setting is the key to this whole thing. And I don't know, I mean, I know good medical studies will compare placebo with medication, but I often wonder, even when placebo does well or when medication does well, there's something, why do some kids do better than others? And a lot of it is just attitude. So I just wanted to share that. And parents also have a way of, out of love, sabotaging the treatment sometimes, because the parents, oh, he shouldn't do that, or protect them. Sometimes there's psychopathology in the family. So it can be a very, very complicated issue. And I just wanted to outline, yes, we're all here for medical, surgical, and all these miracles that these neurosurgeons do. It's just incredible to me. And sometimes even after the surgery is successful, the kids may still have headaches, and the question is why. It may not all be physical complications.
A question? Yes.
This is probably for all of you. It's a pain question. So with Chiari and Syringomyelia, pain is one of the biggest things that most people complain about. So with chronic pain that you have all the time, every day, have you ever heard of anyone, the pain level getting so high that they've had a pain-induced seizure from it?
Pain-induced seizure?
Yes. Never heard of it? So having a seizure because your pain level is really high, the seizure is not being caused by the pain, it's being caused by something else.
Well, I think you want to have an idea about, pain can cause people to lose consciousness, all right? But it doesn't really work into the system necessarily of causing a seizure. Now, there's an easy way to find out about that, and that is to get involved in epilepsy monitoring unit stuff. You can actually see whether there's convulsive activity going on. But when these epilepsy units first became available, one of the neurologists in my group said, well, before you know it, everybody will be using it. And that's true. I mean, it's very widely used now because you can figure out the whole breadth of psychogenic kind of seizure-related things. And it's just important to know, because it's important to treat the symptom no matter what the cause is. If it's epilepsy, there's certain causes for it. If it's psychogenic, there's other ways to manage it. And what the thrust is, it's not to get the goods on somebody, it's really just to treat them appropriately, But pain by itself generating seizure activity, I don't see the physiologic, result in that. Oh, I just wanted to make this is a little bit off the topic, but there's an excellent CD. We were talking about hypnosis and relaxation. There's a CD that one of the Chiari folks made and sponsored a couple of years ago. It's absolutely one of the best 5 and 30-minute self-hypnosis CDs that I've ever come across. North Shore, a couple of other places had tried to develop pre-op and post-op relaxation, tapes. You can transfer it onto your iPod. I use it myself personally, so I can speak for it. I think it's a great relaxation technique, and it's very well done. And it might be helpful to a lot of patients because those things are important.
That's what I have found too, is meditation has been the best thing for me for pain. He actually helps me with that a lot. So thank you for the answer.
Karen, just as you're coming down, can you just comment on, from a cardiology point of view, the whole thing about syncope versus seizure? Because that comes up a lot. And what is your perspective?
I'm on very good terms with Kevin Graber, who's our head of our seizure department, and who's extremely smart. In fact, we at one point threatened to have a funny spells clinic, sort of like I see the patients he sees and vice versa. Typically, a syncope is defined as a transient loss of consciousness with awareness afterward, so that symptoms that occur when someone's lying down, that last for a more protracted period of time, that are associated with memory loss or other more prolonged symptoms, are more likely a seizure than frank syncope. My definition of syncope is a lack of blood flow to the brain and one to your supine. That blood flow should be improved. Obviously, there's some situations in which the blood flow may be impaired by vascular issues that reduce blood flow, but even then the demands of perfusion are much less when lying flat than they are when standing up.
Great, thank you. Yeah. Any more comment on
Sure.
seizure?
Well, I think part of the confusion is what you mean when you say seizure. So, when I think of seizure, I think of a pattern that you see on EEG, electroencephalogram, where you see the brain waves are showing a spike and wave pattern, an abnormal sort of discharge. But some people, when they say seizure, they are just talking about the shaking, the convulsion. So, yeah, right. Yeah, and so for it to be called an epileptic seizure, you need to see that on EEG, which is really helpful. But then something like syncope, where you have lack of oxygen going to your brain temporarily, can cause twitching or stiffening or other movements of the body, and we wouldn't call that epileptic seizure, right?
Yeah, one more.
There was an epilepsy group in New York City that Oren Davinsky, who he gives talks about epilepsy monitoring and the like, and he tells a very interesting story about a very high-profile executive in New York who was having episodes that appeared to be seizures. He would pass out and have jerking. Neurologists frequently, when we get called for something like that, it's called a fit-faint issue, because when people faint, they jerk. You can have what looks like brief seizure activities. Many people will assume that that's the case. Most of the time after a episode of low blood pressure, people will come back instantly. After a seizure, there's usually a postictal period of 10, 15, 20 minutes where individual is confused, disoriented, not able to connect, maybe not even able to speak. or intelligibly communicate. So this post-ictal period is an important thing to look for. But this particular guy had seen 5 top-class, neurology department chairs and significant, expert opinion guys, and they were all treating this guy as if he had epilepsy. They took him into the epilepsy monitoring unit, and they discovered that he was having 6 to 10 second asystoles. Where he went into complete heart block. And they picked that up. He was given a pacemaker. He never had another episode. So one of the things that's important to pick up is cardiovascular things, extremely important. And you don't know about that unless you observe an event. So I have a lot of patients that go to cardiologists and they get a Holter monitor. They get 1, 2, or 3 Holter monitors. And the question is, did you have this? Did you have an event while you were being monitored? If that doesn't occur, then you need to keep looking and keep working at it. Nowadays, it's available as there's what are called event monitors you can carry around for 30 days. So when you have an event, you or somebody else can trigger that, and it records a few minutes before and during and after the episode. So hopefully you can capture some of those things because many of these sudden things are cardiovascular.
I'd just like to support that. And my anecdotal story was, I was just telling Dr. Grant, that I had one patient who was actually a Holocaust survivor, came to the U.S., joined the U.S. military, served in Korea, had traumatic brain injury ×3, and was treated for seizures for 50 years until somebody noticed on a clinic visit in neurology that his heart rate was 40. When we monitored him, he had a 10-second pause, got his pacemaker, and has not had any more seizure episodes. But one advance in technology is the traditional Holter monitor is 24 to 48 hours of heart rate recording. There now are extended monitors that can go 2 weeks or 4 weeks, but there also are implantable loop recorders that are now small enough to be injected that are good for up to 3 years in terms of recording infrequent events.
That's great. More question? Yes.
My question is about integrative medicine. Is there any evidence-based study looking at the influence of yoga, meditation, or MBSR, mindfulness-based stress reduction?
I didn't understand.
I couldn't hear is there any evidence for...
Is evidence-based study in terms of looking at the influence of yoga or meditation or mindfulness-based stress reduction in, with Chiari patients or Syringomyelia?
I don't know if that's been sort of
I don't know about evidence
proven, but
I don't know about evidence-based, but all of that stuff works, and a lot of what the people have said here today is very important. Your mind and your ability to cope with what's going on is just, it's all part of this, and it's very important. Relaxation techniques, biofeedback, cognitive behavioral, dialectical behavioral therapy, all of those are very important.
One of the things I also emphasize to patients is that tools such as cognitive behavioral therapy can be very important in dealing with the frustration of a chronic illness, because often people are referred to psychiatrists or psychologists for therapy, assuming there's a psychogenic component to their symptoms, while ignoring the fact that having a chronic illness, particularly one with a significant pain component, in and of itself can be extremely frustrating. And working with a therapist to develop strategies for pain management and coping with chronic illness can be very effective.
Okay, going back to the syncope discussion just a few minutes ago in regards to neurology and cardiology, syncope versus breath holding. This was one of the very early things that kind of cued us into my daughter being diagnosed with Chiari at the age of 2. And I've kind of had different schools of thoughts. I've had people who swore up and down it was breath holding, and they make me want to get angry and mad and hurt somebody for saying that. But then Dr. Grant put me in touch with a wonderful neurologist who felt like it was more of a vasovagal syncope. We've used Robenal to raise heart rate and blood pressure for the past 4 years now. We're hopefully getting ready to go off. But I just wanted to get an opinion on that.
Breath holding spells.
Yeah. Sorry, I think the question was syncope versus breath holding. Is that right?
Yes.
Okay. And there are a few different types of breath holding as well. And so I think, I'd have to brush up on this a little bit, but the cyanotic, the pallid breath holding spells are associated with syncope, with having, I think, a abnormal phase of a certain part of the heart, a heart beat cycle. I'm sorry, I don't quite remember at this point, but there are some children that start out with pallid breath holding spells that did end up with pacemakers and so forth. So I do think there is some overlap there, syncope and breath holding spells, but the majority of breath holding spells are not likely to be in that category.
Breath holding can do two things. It certainly can augment a vagal response, and also by increasing intrathoracic pressure, it reduces blood flow. So there certainly is not, would be, I have not encountered adults who do breath holding.
Little kids do.
Yes.
Scares the daylights out of you.
Yeah.
I don't know whether it's just a skewed experience, but my experience with a lot of the EDS patients is a lot of the syncopal and tachycardia issues are related to pooling. And the points were made, but I would just emphasize them. The use of support stockings, camisole kind of pressure garments or abdominal binders. Sometimes I have one patient that makes a difference because whether she can walk around or not if she has an abdominal binder on, because her blood pressure drops so quickly. Or not so quickly, but sustained in a way. So these people don't have immediate orthostatic hypotension, meaning they stand up and they pass out. When tilt table testing is done, which is probably a good way to demonstrate some of this, is the patient is stood up at 80 degrees or so with, for about 20 minutes. And it takes sometimes 10, 15, 20 minutes for many of these folks to pool enough that they begin to get tachycardia and then they pass out. I think a lot of the use of propranolol is, or any of the other beta blockers, I find is kind of the first choice a lot of medical folks will go to. But I've had much better, and I was happy to see that Dr. Friday mentioned the mitidrine. I think it's a lot more effective in many ways because a lot of the tachycardia is relating to kind of a hypovolemic response where the tachycardia is just to try to get the blood going. And if you block the tachycardia, people will pass out, whereas if you increase their resistance, you'll increase blood pressure. And it's not the ideal solution. You'd like not to have pooling in the lower extremities, but it's the one thing that I think works better than other things. But I always tell people, if you're averse to drugs, put the leg stockings on, increase your salt intake. Exercise is very helpful because if the more you're deconditioned, the worse the orthostatic stuff is, to the extent that you can do that if you have EDS. And these are many things that can be very helpful in that regard. And sometimes even just the use of mitidrine can be very low doses. In fact, some patients are very sensitive to very low doses.
My daughter has POTS, and she uses the stockings. We use the open toe 30-40 pressure, which is my understanding that you need, and she has them all the way up to her waist, and she doesn't go anywhere without them. The other thing that we've done is we've gone to Hawaii and a few other things, and she uses a cooling vest, and that helps her a lot. It's a vest, and you re-cool the little ice things that you put in just in normal temperature water. So we'd throw them in the ocean, pull them back out, put them in her vest, and she was able to have a nice trip in Hawaii. But a lot of the people with POTS, because of the heat, so between that and the compression hose, she even wears them in the water. Because and if you want to get exercise, going in the water with POTS is fabulous exercise, because if you think of going down to the bottom of a pool, how much pressure is on your ear, that pressure is on your body. So a lot of the people who have the dysautonomia can exercise and try to get going more. So the worst thing you can do with dysautonomia is to lay down, which is all they want to do. So you've got to get them up and get them exercising to get their muscle mass improved the best that you can. So the problem my daughter faced getting out of the pool is all of a sudden she just, everything just dropped into her abdomen and her legs. So she wears the compression hose in the water when she exercises, doesn't have a problem. So the compression hose are good. Bright Life Direct is the website that we order them from. It's the cheapest. So Bright Life Direct. And then the 30/40, and we get open toe so I can monitor her toe appearance. So.
Okay, I think we'll stop there. I told you we'd be able to stop early. Did you have a burning question to finish? Last one? Sure. Yeah. Oh, just 1 second.
Hi, this is going back to the need for sleep. So I have a sleep monitor, and I've noticed that when I get less than an hour and a half of deep sleep through the night, and it tells me how disturbed or moving around I am. But I've tried taking melatonin, and it puts me to sleep, but immediately I start having crazy, vivid, horrible dreams, and I'll wake up an hour or two later, like 2 or 3 a.m., and I can't go back to sleep. So I've done a few experiments, and now I'm doing like 1 Advil PM and 1 Tylenol PM each night, and that seems to put me out, and I'll get over 2 hours of deep sleep. Is that safe to be doing every night versus what you said, like you got to limit it to like 10 days a month, was it?
So I think this probably will be a better question for the sleep specialist who's coming tomorrow, because typically the melatonin, when I'm using that as for headache plus a little bit of sleep aid, it's a preventative, so I use that every day. It's not there's no 10-day limit.
There's some new data that's coming out about the use of antihistamine medications in Alzheimer's disease and in older individuals, and there seems to be, or I don't know whether this is going to hold up now, we get such hot information off the presses, but they're suggesting that Tylenol PM and all, first off, they only work for about 2 or 3 days, and then they sort of lose their effectiveness. The other thing is if you chronically take them, there's some thought that there is brain atrophy and mild cognitive impairment that may be sustained, particularly in older individuals. So, what? Yeah, I'm not sure, it's some stuff that's kind of a tricky in vogue thing to kind of come out with, but you have to weigh the source of it. I don't know if you've tried, tricyclic antidepressant medications like nortriptyline or amitriptyline, which will sort of increase REM sleep. I mean, really the restful sleep that you get is REM, rapid eye movement sleep. So that's kind of what you want. If you're REM deprived, you're going to feel tired and exhausted, and you need that the deep sleep. So I'm anxious to hear what the sleep guy has to say tomorrow, because I think it's a very important factor, particularly in patients with a lot of chronic fatigue. And patients with pain, they go through the night, they're irritable in terms of, they can't get comfortable. So every time they tend to go into deep sleep, they wake up again and move around, So anything you can do to try to get yourself comfortable and sleep through the night and allow yourself to get into this deep REM sleep periods where you can get restorative sleep is going to make a world of difference in how you feel during the day.
Great. Well, thank you to the panel. Really appreciate your willingness to be here.